Hello, everyone. Those who don't know me, I'm Duff Gillespie, Emeritus Professor in Population, Family, and Reproductive Health. And also was the co-principal investigator for the Advanced Family Planning Project, which we'll learn more about today. I'll be joined with Beth Fredrick, who was also the co-PI, and Sabrina Karklins, who was the project director. Both of them were, in the case of Sabrina, before AFP existed. But both of them were, thank heavens for me, were extremely involved in leadership roles with the Advanced Family Planning Project. Okay. This is an outline of what we're going to cover today. There's a lot. So we hopefully will have at the end a Q&A session that Beth would moderate. First, Beth will give a overview of the project and go through some of the reasons why we think this is a very successful project. Sabrina will talk about types of advocacy wins, drawing from the experience in Kenya, which she was, amongst other things, the backstop for that particular intervention. I'll talk about the sustainability of advocacy accomplishments and a little bit more for the need for advocacy. After that, Beth will make a few closing comments and open up the floor for Q's and A's. Before I turn it over to Beth, just a shout out for Oying Ramon, who, when he was at the Bill and Melinda Gates Foundation, was the one that fought about having a large advocacy project. And this is a large project, 14 years, $100 million. So thanks for Oying. Beth, want to take over? I think you have to use this to.
Oh, no. You got it, Ben. I do? Okay, let's see.
There you go.
Oh, I'm going backwards. All right, here we go. In 2009, when Duff and Sabrina asked me to join Advanced Family Planning, I have full disclosure, I wasn't sure it would work. It was way too complicated. 3 countries and lots of different partners and no real clear idea of how we were going to manage all of the different components of advanced family planning. But I'm glad I took the job because I'm here to tell you that I was wrong. It did work, and it worked pretty well. Let's see, I can't do this. Part of the reason that it worked well was that we had 7 principles from the outset. The first was locally driven. And what that meant was that the partners in the countries where we worked always had the autonomy underneath the umbrella of family planning. And by that, I mean contraceptive information services and supplies. They had the autonomy to set their own priorities. That's rarely the case in many projects of this type, and it was part of our success. We were focused exclusively on family planning. We eventually started pilot testing the smart advocacy approach on other issues because we thought it could be used in other areas. But for the first maybe half of the project, maybe a little bit longer, we were exclusively focused on family planning. Our advocacy was evidence-based, and by that I mean we only proposed policies and programs that were field tested and grounded in the evidence around contraception. We were collaborative. So the partner had the grant, but they were expected from the outset to build a coalition and keep nurturing a coalition and sharing the resources among that coalition to be more effective within their country. We were also collaborative, not only at that level, but country to country and globally. We wanted to be influential, and that's part of the reason that we had a global emphasis as well. Because when we were global, we were talking with the donors and with WHO and with a lot of the key actors at the global level. We wanted to be accountable. That was our principle number 6. Accountable meant not only that we would share our results and both our failures as well as our successes, but that we would develop a monitoring and evaluation plan or procedures or programs that could document the results of advocacy, which is very hard to do. For any of you who worked in evaluation, it's a trick to be able to monitor those kinds of wins. One aspect of this is, and then finally, sustainability. We deliberately designed a methodology that was intuitive and easy to sustain and relatively low cost. One aspect of that methodology was the smart advocacy approach, built on a proven approach that was used extensively in communication, but that we adapted for advocacy and that was further refined by our partners. When we think of advocacy, we usually think of it as confrontational. We took a different approach. We like to work with governments and other decision makers. And Mark Sussman, who is now the president of the Bill and Melinda Gates Foundation, a couple of years ago, he was here at Hopkins and I had the chance to sit down with him. And he said to me, if we had not given you money over a long period of time, and we had ended at the first grant of 3 years, we would have seen a failure. It took the full 14 years, and you'll see in a second what that meant, to deliver results at scale. So as I said from the outset, we saw the interplay of synergy between countries, regionally and globally. And following the vein of swimming with the current, which I didn't actually touch on in my prior slide, we became trend spotters for family planning advocacy opportunities and a strong community of practice. Swimming with the current meant that we became friends with government and decision makers. And that meant some of them were often in our coalitions and gave us the intelligence about the things that they were frustrated about that they wanted to move forward in their countries or subnationally. We developed a strong community of practice, and you'll see that we had 8 focus countries and several regional networks throughout the 14 years. We also had an opportunity fund that was able to quickly provide funds to advocates in different countries outside of the focus countries so that we could take advantage of some of the things that were happening in different countries that needed just a little bit of a boost to get forward movement. And then we were always aligned with other investments. And so we were always building on the back of the investments of donors, both country donors and private donors. So I'm going to go into a little bit. I talked a little bit about the M&E approach. And these are the types of advocacy wins that we were able to record over the full 14 years. In some cases, we were a little bit longer, a little bit shorter. So from 2009 to 2022, you can see the trajectory of what Mark Sussman was talking about. The first 3 years, we would have been a failure. Look at how small it is on the bar to the left. And as we progressed, we saw that one of the biggest areas of influence that we had was on budget allocations. So the budget allocations went from getting a family planning or a contraceptive, something around contraceptive in the budget, in the draft budget, then keeping it in the budget, having the funds allocated, and then seeing if they were expended. So along the way, you can see that we developed such strong relationships with people in government that we were able to know exactly how to leverage advocacy for greater investment. Expenditures, we couldn't, I'll tell you right now, we couldn't really document that as much as we'd like to. That would be something that would come out of a new project down the line. So at the bottom, it's budget wins. In the middle, in the middle bar, it's policy wins, everything from overcoming an old colonial law in the Democratic Republic of the Congo that forbid contraceptive use. I mean, they went around it, but it was nice to get it out of the law. To guidelines for pharmacists, pharmacy students in their curriculum. Also at the top, there's a tiny little green bar, which was an experiment that we started on media advocacy, because along the way, we wanted to hold policymakers more accountable. So media advocacy was built on to smart advocacy and became a new approach for media advocacy. We weren't trying to get the media to get the public to think positively about something. We were working with the media so that they would hold policymakers accountable. And here's what happens when you have a long-term goal and a long time span for advocacy. You can see here that the subnational units of government, which became very influential in the first 3 years of advanced family planning, took over a lot of the budget wins for us. County, state, provincial leaders were all willing to they had authority over their budgets, and they were much more easy to persuade because they were with their local constituents. So by the end, Duff mentioned that we were a $100 million project. By the end, we had mobilized from domestic resources and private sources, $185.7 million from 2012 to 2022. So that was a pretty good return on investment for advocacy. And now I'm going to hand it over to, no, I've got one more. All right, so I think the beauty of advanced family planning was that we were integrated globally, regionally, nationally, and subnationally. We learned from one another. We were trend spotters, finding different things that might influence any one quadrant of this circle, and they built on each other. One example that Sabrina is going to go in depth on is task sharing for family planning. And task sharing at the beginning of advanced family planning was the focus of a lot of research at country and national, at country level, to see whether or not it was feasible, accessible, and safe for community health workers, for example, to provide injectable contraception. Governments were not quite convinced about that. And the researchers hadn't quite had the leverage that they needed. So we had an opening. When I say we were a trend spotter, we had an opening to see whether or not we could get governments to buy into this. One of the biggest early advocacy wins that we had was advantageous at the global level, not at the country level, when one of our partners, Marie Stopes International, realized that guidelines were being developed by WHO at that time for maternal health. And they weren't incorporating family planning. So task sharing guidance from the WHO, maternal health, didn't incorporate family planning. So within a very short time period, we provided the funds and mobilized the advocacy effort to bring in an expert committee that would develop the evidence base for incorporating the capacity of community health workers and other cadres of health workers to provide family planning. It was probably one of the most influential, but it built on a lot of work we'd already done in task sharing, and then it opened up a big area of work for us in advanced family planning. And now you'll get to hear from Sabrina about that. You move it ahead. Just the little here. Now it's. Oh, there. Okay, great.
Okay, so thanks, Beth. So moving from a change in medical guidelines from a well-respected, known global organization like WHO to now countries updating their own policy and guidelines is a whole nother effort that doesn't happen immediately and not without some challenges. So in all of our AFP focused countries, most of them, and in some of the regional work, many of our advocacy efforts centered around the initial WHO task. We kind of switched between task shifting and task sharing guidelines, the updated guidelines that expanded service provision to community health workers to provide contraceptive injectables. And in the countries, our advocates quickly realized that a constellation of advocacy efforts needed to happen for task shifting to really happen or to be a reality. And what I mean by that is that for services to really be offered to women and couples in their communities, family planning services. So in this beautiful illustration here, there are a number of advocacy efforts that happen in all of our AFP countries. I'm not going to explain each one of them, but instead I'm going to share a little bit of what happened in Kenya. We had a long-running project in Kenya with our lead partner, Jopaigo Kenya, and I would say that we pretty much hit every one of these buckets. So let me try this now. It shouldn't be that hard. Oh, wrong way. Why is it doing that? Yay. Sorry. Okay, so in Kenya, there had already been lots of discussions around task shifting to community health workers as far back as 2006. Kenya had already had national family guidelines. They endorsed the MDG goals, and through two international organizations, INGOs, Jopaigo and FHI 360, they had a USAID funded pilot project in one county, Tharaka Nithi, to test the feasibility and safety of community health workers providing contraceptive injectables, and that happened between 2009 and 2010. While there was favorable policy environment, and now there was evidence from this pilot project, policymakers and programmers realized that there was kind of a stall in the family planning program. So the prevalence rate for family planning was low, access in rural areas was limited to none. And there was this realization that Kenya was not going to reach their MDG reproductive health goal, which I believe was number 5B, was not going to happen by 2015. So in addition, despite the evidence that the community health workers can safely provide injectables, and now in line with the new WHO guidelines, there were still key medical, nursing, and midwifery associations in the country that were not on board for updating the guidelines and including this new amendment. In 2011, AFP began work with Jopaigo Kenya. As I mentioned, they were our lead implementing partner, and had the endorsement from the Division of Reproductive Health Service, which is what the division was called at the time under the Ministry of Health, brought together a group of family planning advocates to develop a SMART strategy with advocacy actions targeting key decision makers, those that were not for the amendment, that were objecting to that updating the policy. They included directors from, again, these were the divisions that were labeled at that time: Division of Medical Services, the Division of Public Health and Sanitation, and several leaders of the nurses and midwifery associations. There weren't just one, there were several of them. Over the course of several months, advocates presented data and evidence to these associations at various convenings. They also made site visits with them to the pilot county, Tharaka Nithi, with the leaders and the directors. In addition, there were multiple meetings with each leader, talking with them, listening to what their concerns were, and addressing any of their worries or their concerns. After seeing the data from the pilot study, the directors from the two divisions, from the two health divisions, they were convinced somewhat quickly that amending the policy was in the right direction. So that was kind of an easy win. On the other hand, there was a chief nursing officer and leaders from 2 nursing associations. They needed more assurances that there would not be adverse events. The nurses at the time already felt overworked and under-resourced, and they felt that this was kind of like task sharing and that they would just be getting more work and that it wasn't a shifting. And that they would now have to supervise, they would just have to have more supervision duties. So in order for them to have their endorsements, they required additional language in the policy. And that was to ensure that there was supportive supervision of community health workers, not necessarily under them, to be added to the amendment. And so there was agreement to that, and the additional language was included. So after all those meetings and convenings, 6 months later, in 2012, Jepaigo, Kenya, along with the 2 division directors from the Public Health and Sanitation and from the Medical Services, jointly signed a policy circular that amended the Kenya national guidelines to allow community health workers to provide contraceptive injectables. Later in the year, there was a formal public launch, because you just don't want the policy to be put on a shelf, of the updated policy by the ministry. So now everyone knew that the policy was amended. Again. Why? I barely touch it. Really, I don't know. Sorry, I don't know what it is. Okay, so moving from national, now that there's a national policy in place, doesn't mean that it will get implemented. And in the case of Kenya, implementation happens at the county level. Kenya moved from a parliamentary to a presidential system and devolved into 47 counties after the 2010 election, with each county having governance and budget authority. What that means is that what happens at the national level needs to be repeated at the county level. The process begins again. In the counties where Jepaigo, Kenya had already had projects, they started working with the County Ministry of Health. Each county has its own Ministry of Health. And then another entity or agency, government agency called the County Health Management Team, again, to form a advocacy coalition, if you will, or working group that included members from organizations that delivered family planning services on the ground, faith-based and community leaders, public health clinicians and nurses, youth, etc. And together they developed a smart advocacy strategy for the county to adopt the national task sharing policy at the county level. And similar to the national level, once the policy was approved, there was a public launch. So everybody knew that there was now a county level policy. But what happened next was really key. The group then came back together to advocate for the development of a multi-year costed plan that supported implementation of the new task sharing or task shifting policy. This was then followed by additional advocacy for budget allocations in each fiscal year. Some years were better than others. And what I mean by that is allocations sometimes matched the previous year. Sometimes they were higher, sometimes they were lower. Funds went towards training of community health workers on quality of counseling, to ensure safe provision of injectables, sometimes for stock procurement, and in some case monitoring the program. As you can see in the picture here, that is a community health worker in Narok County, one of the counties in that Jepaigo had a presence. And in that county, they did a quick 3-month survey after they launched the project, looking at uptake of injectables. They did see an increase use among new users, repeat users, and adolescents. I'm pretty sure there's likely an counting or overlaps in counting, but overall the program looked promising, especially reaching youth, adolescents with their contraceptive needs and wishes. So what I just described happened across several counties in Kenya. Counties also use smart advocacy to develop plans to address high rates of teen pregnancy, to improve postpartum family planning, and overall to improve data systems in their counties. Okay, I think this is the last slide on my group. All right. So lastly, I'm going to take you back now to the national level. So when WHO revised the guidelines for community health workers, there was also discussion around the pharmacies and drug shops. So if you actually go into the document and you look at the matrix, you already see pharmacies are listed in the, as one of the cadres. And so once again, at the national level, pharmacies our advocates now focused on amending guidelines to allow for pharmacists, and in Kenya, they also have pharmacist technologists is what they're called, to provide family planning counseling and family planning method provision, including a newly released contraceptive method called Cyanopress, which is DMPA-SC, the SC being subcutaneous under the skin. IM is the intramuscular version of that. I'm not going to go through each of these advocacy efforts, which are also advocacy achievements related to the pharmacy task shifting work at the national level, but you can see them here. But I do want to show towards the end here, the ones that we're working with. They're at the top. The Pharmacy and the Poisons Board, working with the top universities in Kenya, approving a Common Core pre-service curriculum for pharmacy students. This is super important because it was a way to treat new pharmacists, before starting their practice. And instead of trying to do refresher trainings across the country with, all the pharmacists that were already in training. Also, this has great implications because DMPA-SC is also sort of thought to be the next contraceptive for self-care. And so Kenya felt that with these things in place, the next policy to be amended would be guidelines around self-care for DMPA-SC. So to wrap up, there was an impressive run of advocacy achievements around task shifting and its implementation. In Kenya, it was important to have the right people at the table, including key champions, such as even a county first lady or a governor. Each of the strategies targeted decision makers with messages that made a difference and spoke to their issues and the things they cared about. Evidence and data, while not always critical, were certainly important for some of these decision makers in Kenya, as I mentioned earlier. Advocacy strategies, if smart, can be accomplished in a timely manner if there are not unforeseen events such as a strike or a decision maker removed from office. And advocacy doesn't require a lot of resources. Mostly it requires advocates' time and expertise, their connections to be able to convene and to convince. And at that, I will turn it over to Duff to talk about an assessment in India. And I think you have more expertise on that.
Let's see, Sylvia, you might want to start up here. Oh, I did it. One of the chronic problems that anybody that works with projects is something we used to call projectization, which is you don't know what happens after the project ends. And very frequently, there's no funds for actually doing a post-project assessment. And even if you see that some of the things you're trying to influence, let's say contraceptive use, goes up, you don't know if that was a result of the project or many other factors that influenced, in this example, contraceptive use. So we want to try to address that, even though that type of research was not in the original project design. First, what is sustainability? I think just a straightforward, simple definition works best. And that is that the advocacy continues after external financial and technical support ends. And advocacy can fall into two broad types. One, were the programmatic funding changes that were a product of advocacy continued? So that's sort of did the actions that you won continue? The second is advocacy activities itself, the enterprise of advocacy. Does that continue? And we're going to look at both of them from a study that was conducted by Chicago, India. Oops. All sorts of buttons here, but half of them don't work. So the assessment study was from August 22 to July 23. I think I skipped a slide. This is the intervention, broad brush, that Chicago did. It was from 2012 to 2019. It was a big project, 42 districts in 6 states, and some districts are larger than the population than the state of Maryland. In 6 states, covering an area of 118 million women of reproductive age. Our local partners were Foundation for Reproductive Health Services, India, which is formerly MSI India, Pathfinder India, Population Foundation of India, and Chicago, India. Now, the project ended in 2019 because the Gates Foundation, which was the largest donor supporting AFP, decided that this would be a good opportunity to put in motion their localization, their local ownership. So they stopped funding it in anticipation that the India office would take it over. The India office, after much going back and forth and some disagreeable interactions with them, they decided not to support it. So the project ended. That presented an opportunity. At the time, we didn't realize that, but an opportunity of getting permission from the Packard Foundation, who had no qualms about putting money in India activities. So we used some of their money to actually mount an assessment. Roughly 3 years after the end of the project. Now, during that 3 years, the pandemic, COVID-19, hit India pretty hard. We'll see some of the consequences of that. I won't go through all the methodology, but here are the highlights of the study plan. Of the 42 districts that were intervention districts, 26 and 6 states were assessed. They did this through focus groups and key informants. In addition to that, 101 facilities were actually examined, looking at statistics and various other things, service statistics. The sustained advocacy wins. Of the total number of advocacy wins in India, 324, we were able to track 204, 63%. We thought this was amazing after a 3-year gap. And we're also talking about not just large numbers of peoples and programs, but a very wide geographical spread. Of those 204 that were wins that were tracked, 182 or 89% had some sustainability of the activities that they were addressing as a result of the wins. Either a funding increase, programmatic change, were continued. So we thought we were quite pleased with that result. Beth mentioned that many of the activities that were addressed were budget. And this shows and reinforces the point that she made that it takes quite a bit of time before your advocacy efforts begin to have a return. So you can see it wasn't until 2016 that funds were increased. Some of that is due, it just takes a long time to do advocacy. Some has to do with the budget cycle in India. So it climbed up really steadily, and then you can see in 2020 the effect of the COVID pandemic, and there was a drop. And that drop was more than made up in 2023. That huge increase is mostly due to states taking some of examples of wins and greatly expanding it. So let's say that in one district, there was special training for outreach workers. That was expanded to many more districts, thus increased the funds. So it was funds that were tied to the original advocacy win, but the magnitude of those was greatly increased as they expanded. And most of those, not surprising for those of you who know India, the bulk of those increases occurred in UP, which is the largest state in India. Just a couple of examples of sustained wins. So of the district working groups, 85% were still operating either independently or as part of a larger government community working group. The district working group, each district had a district working group. The district working group decides what advocacy activities would be undertaken. So what you get is a kaleidoscope of different wins. So one district could have a series of wins, and next door district would not have that same combination of wins. It's going back to local ownership, something that Beth mentioned, and that we consider very important. Interesting, of the working groups, 68% were still using the original AFP guidelines. So here again, we were pretty pleased by that. One of the things that a lot of the districts had were counseling corners. These were literally physical corners that had some privacy that allowed counselors to have a more or less private counseling session with clients. 46% of those in the facilities where there were counseling did have counseling corners and were assessed, had 46% that were still using them. You can look at that as half full, half empty. I think we choose to look at it as half full. In addition to those types of activities, the advocates in India were very committed to health and family planning. They're champions. So many of them were very active in training other organizations, other people in a smart advocacy approach. 93 advocacy facilitations, training programs, 130 NGOs, and some 193 government officials. We have lots of anecdotal examples of how that advocacy activity and training was translated into not just advocacy for things, but a lot of the organizations used smart advocacy for running their own organization. The approach SMART was originally a management tool developed in the 1980s. So they applied that. So, should we go to this conference in Japan? You would do a SMART analysis and say, no, we shouldn't, or yes, we should. Some examples of service changes post project. You looked at post-abortion sterilization. You can see, and post-abortion IUD. These are 25 facilities in which there was an in-depth analysis. You can see the effect of the pandemic in 2020 figures. But after that, not just a nice recovery, but a sizable increase in those facilities that did not offer those services before the AFP intervention. talk a little bit about the need for advocacy. A switch to a global perspective, or more specifically, to USAID and other government agencies concerned with foreign assistance. Some of you who've taken my class have seen this, our Beth's class also. There are lots of messages in this, but some of the take-home messages I want to concentrate on was that if you look starting really in 2009 or 2010, that the amount of funding for international health is pretty flat. And interesting enough, it's flat across all sectors. So it's not like family planning took an extraordinary hit where maternal health made a gain. They all pretty much stayed static until we get to, see if I can read my notes here, 2020 and 2021. And you can see the turquoise at the bottom, that's COVID-19. And at the top, the light blue, that's the Global Fund that was very involved in the disbursement of COVID-19 funds. So those 2 years, the increase is due almost entirely to COVID. The next 2 years, with roughly $12 billion, is also due to something extraordinary. It's the black part of the bar, and that is for global health security. That's not like your traditional health funding, that's more for emergencies. So a sudden influx of refugees into Kenya. These funds would be to address problems like that. We're not gonna have time to talk about all the reasons why this, and believe me, I could talk for hours and could have a narcotic effect on all of you. But one of the things I will mention, will come to no surprise, is that part of this is a result of a dysfunctionality of the federal government. So you have funding done at the last minute through something called a continuing resolution. We're at the position now that the best predictor of next year's budget is what the budget is this year. And that's not a good responsive way to deal with something like global health or maternal health or any of these other things. So another reason, this is something that I really have gotten more almost pathologically involved in, is what's happening with what many observers now call a perma-crisis. And this is a state of affairs where decision makers and programs are constantly, daily, dealing with one crisis after another. I had the opportunity to talk to a couple of senior personnel at USAID about their attempt to do localization, local ownership, which is kind of stalled, even though it's a very high priority of administrator power and US government in general. I said, is part of the problem that the senior management is constantly dealing with emergencies? He said, absolutely. That most of their day is dealing with an emergency that maybe didn't exist yesterday. The thing that is particularly important, besides the absolute increase in a number and intensity of these crises, is that many of them are polycrises. That is, a wildfire in this particular area has influence on food security, on air quality, on displacement of people. So it has a rippling effect into other sectors, which makes it very difficult to deal with, because that means that different parts of the government have to deal with different segments. Now, this collage that Sabrina put together, anyone could do this after reading the New York Times or Washington Post for a day or two. In fact, you could probably make it even more complex. And there's quite a diverse number of things here. So we're dealing with that. So how has USAID and the federal government responded, particularly USAID? Crap. Sylvia, help me. Yeah. Yeah, that's it. I don't know how you did it. It's great. Thank you, thank you, thank you. It's not us, by the way. This is, there's all sorts of buttons here, and I can't figure out. The three of us are not, all of us are not incompetent.
No.
Who said that's not the case? Okay, so anyway, USAID just March of 23 issued a new framework, policy framework. And they titled Confronting the Greatest Challenges of Our Time. Now, this is very different set of pillars or priorities than when I worked at USAID several decades ago. Emergencies, peace, and resilience, and lasting food security. By food security there, they mean dealing with a drought. They're dealing with an infestation of locusts. They're not talking about new agricultural techniques, which goes elsewhere. Climate change, authoritarianism, basically a threat against democracy. Then we get to what most of us can relate to, health systems and economic and social development. So these first three are basically things that I would say are part of a response to a permanent crisis. And a response that needs to be done. So we're not talking about dropping those and concentrating on these others by any means. But it has consequences. And one of the things I was interested in was looking at how this might affect, this shift in paradigm might affect decision makers and policymakers within USAID. And one of the things I thought, well, let's look at the press releases, and lots of press releases, over 2,000 in this period of time. Most of them were press releases having to do with administrator power or her deputy, Coleman. So this is, I think, a good indication of where they're putting their energy. And you can see that the first three, those that were very tiny part of the agenda, development agenda when I was in that field, is 71%. So 71% of the press releases have to do those first three. The amount of funds, which aren't shown here, is 58%. So 58% goes for those first three, but over 70% of the activities go for that. What about an area that many of us care about a lot, family planning, reproductive health, which is embedded in the health? Well, of the 2,000 plus press releases that took place, family planning was never mentioned in one. And the reason I know all this is you could go to the website yourself, is that some poor person or persons actually did a content analysis of all these by categories. So you can actually click on reproductive health or oral rehydration and see how many press releases concern oral rehydration, for example. So family planning didn't make the cut. So you can look at that in terms of a disinterest or even maybe a hostility for family planning by the leadership of USAID. That's one way of looking at it. Another way of looking at it is that family planning and reproductive health represent, any guesses on what percent of the overall USAID budget? 1%. So in one sense, it's reasonable for them not to have any press releases on something that concerns 1% of their budget. That said, it means basically that family planning, reproductive health is not on the USAID or the United States development agenda. So how do you go about addressing that? Well, some organizations are attempting to do that. And you probably all have seen articles that try to link climate change to population dynamics, or even security, armed conflict, to population dynamics. There's lots of articles. As far as I can see, they've had no impact at all. And there's lots of reasons for that. One of the reasons that I think it is that I'll give you an example. So one of the things I came really engaged in when I was at USAID in the early 1980s was the relationship between population and the environment, and particularly biodiversity. So we had a number of small projects. We had one in Costa Rica that worked with communities that were neighboring a national forest. And they would go in and cut timber and even had plantings for crops. So we worked with them about the importance of family planning, but also the importance of the environment at the same time. And saw some success in the sense of people stopping, going in, chopping down trees, et cetera. And we thought, it's evidence-based. Let's go to the Minister of the Environment, which was not his name. That was basically his title. I mean, his remit. And we explained that. He was engaged. And he said, looks like I'm going to have to build more walls and fences. And then he thought about it. Well, yeah, that's a natural reaction because he controls that. He has nothing to do with family planning, nothing to do with community development, but he can control building fences. And that's when you get into the problem of a poly crisis, is that it involves many, many different players. So that's the situation that I'm going to quickly turn over to Beth, who's going to tell us how we can address this and open it up for questions. Beth?
Okay, so whenever Duff gives this part of any sort of lecture, I feel like people are just gonna cry and run to the bathroom and don't want to be put your head under the sand or whatever else might happen. But there's a legitimate reason to be pessimistic about both advocacy and advocacy specifically around family planning and reproductive health and rights. And I'm not going to read through these because this is only skimming the surface. But I do want to say that there are some glimmers of hope in terms of advocacy and advocacy on the issues that we care about more deeply. And one of them is that the smart advocacy approach will evolve and continue to be used in public health and other issues. It is something that has taken on a life of its own, and it's self-perpetuating because of the partners we selected, but also because it's a highly intuitive, low cost, as Sabrina said, low cost methodology. The funders aren't discontinuing support for advocacy. They're trying as much as they can to shift their investments to groups in and countries and even subnationally, so that they can invest more in the people who already have the skills and who are closer to the issues. It's proven difficult, and not much of the money is moving to those organizations, and the level of funding that we received is not being shifted in that scope and scale. But citizens also know how to mobilize and use communication channels. All of you probably do it. And advocacy is now seen as an essential, accessible, and effective tool for public health professionals. When we started AFP, there wasn't a core competency for advocacy. And I think it's one of the best things that's happened in we didn't do it, but it's a really nice admission or recognition that advocacy is important for public health. So with that, questions, and I assume, Sylvia, you're looking at the Zoom in case somebody wants to raise their hand on Zoom. Questions? Oh, all of you too. Yes, Mo.
Yeah, I was wondering about when we were doing the overview of the successes in India, if there was like geographic clustering of where the sustainability efforts were maintained, and if there were like patterns.
Why don't you come up and stand next to me?
I'm not sure, Mo, that there was a geographical cluster. But the biggest reason for them not having continuation is change of personnel and decision makers. That was the most common reason that they could determine. They did a very clever sampling of the 26 districts. They took, and won't have time to go through all the criteria, but they took for each district classified as a high performer or a low performer. So half of the 26 were high performers, and the rest were low performers. So in one sense, these are probably, well, I don't know if it's high or low, but these are pretty rigorous way of determining whether or not things were sustained.
Sorry, I have a quick follow-up. If there were patterns with like the turnover that you mentioned at being the main reason, did it matter like what level that turnover was happening? You know, local, subnational levels or national levels?
These were all subnational. The most important person was the person who farmed and kept the district working group, not just existing, but active. But it was a mix.
Thank you.
Andrea?
Thank you so much for the presentation. Really nice. And for me personally, it's very nice to see the three of you together giving this presentation. So I have two questions, if I may. So number one is, can you talk a little bit about the value of doing this type of work out of Hopkins, out of the #1 school of public health in the US? And the second question is, if you were to continue doing this work with funding as before, what would you change? Would you change partners? Beth, you talked about selecting partners, but what else would you change? Would you change the approach in any way, the partners, the countries where you work? I don't think you can influence what happens with the elections necessarily, but probably that can be, a way to guide your.
I think
your
we're
approach.
prohibited from doing that.
Thank you so much.
So the relationship with Hopkins was essential. And I can tell you that I have been involved with Hopkins when I was with Guttmacher and the International Women's Health Coalition. And I got here and I got my business card and then went into my first meeting with a decision maker and said, I'm from Johns Hopkins. And they were like, oh, yes, well, sure, you can come in and talk to us. And it was really important for us initially, because it sort of softened the ground for what we were trying to do. But it also allowed us to, our partners, to have a little more gravitas too. One of the other elements of being affiliated with Hopkins was that we were, when I was talking about trend spotting, if you actually think about all the different research things that are happening at Hopkins, you can see what's happening in terms of the new scientific developments, and in terms of the new trends in use or non-use of different methods. And that was really important, because then we could come in and solve a problem, or we could take advantage of something that was already happening. So that was really, I do have to say that Hopkins in the later years started to become a little bit of a I don't know why, but the part of this localization, I don't think they understood we held the money, and they wanted the money to be much more dictated by the partners, but they had autonomy. As I said at the outset, we determined the amount of money, but they gave us a plan by which we determined that budget ceiling. And the second question was,
What would you change?
what would we change? We can all do one. How's that? I would increase the accountability in media advocacy work, because I think that all of these policy changes are fantastic, but then they have to actually be made manifest.
I don't think I would change anything in terms of the advocacy enterprise. Because it was done not by us, but by our local partners. And we avoided the temptation to second guess.
Mostly.
Well, I also should point out that we had some wonderful partners, but we also basically dumped a couple of them weren't so good. And we did that quickly, which is good we have foundation funding. So if they weren't performing, they were.
And Sabrina, how would you answer that question?
Same accountability, communications, maybe some more M&E on our side. And not so much changing the tool, but it was used for other topic areas. So gender was the next sort of area where advocacy was, where the tool was applied. So.
Yeah. And Celia Karp and I teach the online smart advocacy course, and we are completely convinced that it can be used for almost anything.
I do want to add something, not about Hopkins per se, but I think what we heard, and this is more, I'm saying something that our partners have told us when the project ended, is that with this drive to fund locally, what is going to be missed now is the connection to the global. And even though it may not be Hopkins, but it could be something else, but our partners really benefited from getting some of the intel, not just the research, but what's happening at USAID, or what's happening at the foundation, or just the connective piece. And so now or aggregating information, and just that push through of information. And so I think that's going to be a missing piece.
One more question, and then we're on time. Anybody have another question?
If no question, then let me ask one question.
Yes, Saifeddin.
Yeah. Now, given all the learnings we had during all the years, okay, and if you take the advocacy framework, okay, and even particularly during the COVID period, we have seen that how the political forces could be more powerful in mitigating the voice of public health advocacy, right?
Mm-hmm.
So what is your some sort of a strategy or some sort of a framework you can think about in mitigating those type of the political force? Because I'd say record number of the national election will determine, right? So what is your lessons learned on this type of the political issue mitigation? How do you do that?
Well, I think people are doing it. what I think is distinctive about advanced family planning is that we were funded at a level that could sustain advocates who had, we only had a few people in the team, in our partners, who were full-time advocates. We were, so that the head of an organization could play a role when that was appropriate. And so there was funding for their time to do that. Prior to our advanced family planning work, there were rarely advocacy programs that would enable that to happen. So the whole team could go out and advocate. But I don't know, what would you say to that question?
No, I think that's a good response.
So I hope that more folks in other parts of the world are beneficiaries of the localization agenda. We're not seeing it, and we're not seeing it on advocacy. And that means they're back to doing it part-time on their own time without sufficient salaries. Carolyn,
Just one comment, the money's not mobilized.
no, that's right. That's right. So who knows what will happen, but we hope it will continue in some fashion.